A bunion is a bony bump that forms at the base of your big toe. Your doctor might diagnose it when you cannot fit into your shoes or walk without pain anymore. A bunion is a painful and unattractive deformity of your foot. 1 in 3 European women is affected by this deformity. Is this a disease of modern society? Are high heels a common cause of bunions? We will find out with the help of Dr. Rahmanzadeh, who promises to fix even the most severe cases.
Nicole Herold has been wearing flats for 2 years now. The deformity of her big toe has become more painful over time. This is not her fault, she presumes.
Of course, I have been wearing high heels in the past, but the bunion seems to be genetically preconditioned and hasn't been caused by fashion shoes.
She's barefoot or wearing socks around the house, but that doesn't help. The onset of pain in her inflamed toe forces her to stop and massage her foot.
It is a sharp pain that's hard to describe.
Aber es sticht direkt hier vorn auch und geht dann einfach nicht mehr.
She has tried to fix this problem through physiotherapy, to no avail. This is why the 36-year-old went to see an orthopedist to get her bunion looked at. Clearly, the big toe is crossing over the second toe. Here you can see the metatarsal head pushing against the skin. This is most likely the pressure pain point when wearing shoes. The inflammation of both periosteum and bursa sac located underneath are causing her considerable pain. Nicole is shown X-rays of regular feet to compare with the deformity of her foot. Her metatarsal has progressed rather distinctly towards the second toe. The doctor recommends surgery.
Today we will discuss a particular technique for this type of surgery with Dr. Rahmanzadeh. Welcome and thank you for being here. You have developed your own method. This is what we will talk about today, but first, please explain how the bunion comes about. Are high heels really the only cause for bunions? In the Western world, 1 woman out of 3 is suffering from this type of deformity.
I am convinced that this is mainly a genetically caused ailment. There is a lot of literature to prove this point. Some people argue you won't see many bunions in part of Africa, where people forego footwear. But then again, this might be related to a different genetic type. You might find there is no genetic disposition, and thus no bunion. I consider the latter more likely. Back to your question regarding high heels. I presume things are blown out of proportion. Wearing shoes that are wrong for your feet will enhance pain and deformation. The bunion will surely become worse by wearing fashion shoes and high heels. Occasionally, I believe that's not so relevant. I do believe the genetic disposition causes 90% of the condition.
Ab und zu, glaube ich, ist es nicht so schlimm. Ich glaube aber, dass die genetische Komponente fast zu über 90% immer zugrunde liegt.
All women were quite interested, and we ended up speaking at length about bunions and whether men are affected by them at all.
I operate on about 600 feet per year. For the last 10 years, approximately 20% of my patients are men, which underlines the genetic disposition. I do ask my patients whether their parents or even grandparents had this kind of problem. It is quite interesting to see. The bunion might skip a generation. Patients tend to mention their grandparents.
When do you consider surgery necessary? This is not just a cosmetic issue. It can cause severe pain. When would surgery be required?
The degree of pain is the decisive factor. Also, the degree of bone deformity, meaning there can be a minor bunion that causes major pain. A bunion can be prominent without causing any pain.
Oder es gibt einen Hallux Valgus, der sehr stark ausgeprägt ist, aber überhaupt keine Schmerzen auslöst.
This model represents a fairly subtle bunion. We are able to distinguish a consecutive reaction to the bunion, turning the second toe into a hammer toe.
Einer sekundären, einer Folgereaktion sprechen können, dass sich
Due to the footwear, the big toe has crossed over underneath the second toe. The second toe has detached from its joint, impossible for it to realign. It will remain in the wrong position and cannot be controlled by movement. This might cause painful inflammation, such as a corn, as can be seen here on the metatarsal bone.
The problem here is as the bunion is growing and further crossing over to the second toe, the affected joint of the big toe will continue to twist and progress towards the middle of your foot. The gap will only become bigger. This type of wedge between first and second metatarsal is defined by the genetic disposition of any patient suffering from bunions.
The bump we can see here is a soft tissue bump, for example, a bursa. With reoccurring inflammations, it will develop multiple superimposed layers of scar tissue. Imagine them in the shape of an onion. It seems the actual bunion might be growing in size when it is really just adding layers.
Hallux Valgus knöchern größer wird, dabei wird an und für sich nur so knorpelig, narbig, weichteilig größer.
As mentioned earlier, you are an expert in this field. You have developed your own method of surgery, which we would like to introduce in this short clip. We will then talk about these interesting plates. Let's take a look at your work first. The bunion usually occurs on both feet, though it is recommended to operate 1 foot at a time. After surgery, there is a period of several weeks where you cannot put any pressure on your foot. Dr. Rahmanzadeh operates differently. He operates on both feet simultaneously by cutting through the bunion using a very specific technique. He cuts out a wedge and then puts both parts back together. The new break is being fixed with Titan plates in such a firm way that patients don't experience any pain after surgery. Within 2 days, patients are allowed to walk normally without the use of crutches. 6 months after surgery, the Titan plates will be removed under local anaesthesia. By then, the gap between the bones has disappeared. The principle of this method hasn't changed. These were archived images from 6 years ago. Back in the day, our small plate looked quite straight. This is a screw that will go into the bone. Nowadays, this is the tiny part we are working with. You can see a significant difference. One is bent, one is perfectly straight. What is the main gain of this improvement?
You have described it quite well already by keeping to what we had discussed earlier. It is rather easy to understand. It's all about getting rid of the bunion. How can I move the first metatarsal bone towards the second one? How can I fix the bone in that position and prevent it from sliding? Over time, I have made a technical change. This is the plate developed by me that I have used until recently. As you have demonstrated before, this is a plate with a flexible screw.
Sie gezeigt haben, die Schraube nicht fest im im Plattenloch drin sitzt. Das heißt, die Schraube und der Kopf ist beweglich. Im Laufe der Zeit
I have modified the plate several times over the years. These days, I am using an asymmetrical plate as shown on this bone. In this case, the asymmetrical plate has a flap that keeps the metatarsal bone in place. It keeps it from sliding back towards the central axis of your body. A recurrence of the bunion is thus made impossible. I have hardly any recurrences. Any foot surgeon will have recurrences. In principle, thanks to this special plate, we don't have any.
jeder, der Füße operiert, hat auch Rezidive. Und bei mir kommt das im Prinzip, ich glaube, vor allem durch diese sehr stabile Platte gar nicht vor.
Well, this all sounds very good. There is one hurdle though. This surgery is for people with private healthcare. What are the costs for patients on Medicare?
Erstmal nur für Privatpatienten. Was muss man zahlen, wenn man so wie ich bei einer großen Krankenkasse versichert ist?
Ja.
In the beginning, I was trying to control the high numbers of patients. Since I am in private practice, this method became public too. In the meantime, things have changed. The surgery in hospital will be paid for, even for patients on Medicare. The cost per foot amounts to €1,700. The anesthesiologist is paid €300 to €400.
Der Patient, der Kassenpatient ist, bekommt auch die Operation bezahlt im Krankenhaus. Nur ich muss in irgendeiner Weise allein schon rechtlich den Patienten liquidieren. Und die Operation kostet pro Fuß €1.700, wobei aber auch der Anästhesist, der im OP-Saal sitzt, nicht weinen darf und auch mitverdienen muss, wenn ich verdiene. Insofern muss der auch ca. €300 bis €400 verdienen.
Okay.
Thank you very much for being here. It is unusual to operate on both feet at the same time. It enhances the healing and recovery process.
Time is of the essence. It is no problem at all to operate on both feet simultaneously. That's what I do 70% of the time. The rehabilitation period is actually cut in half.
Thank you very much for this interesting insight into feet and plates. We have put a summary of this topic online. Thank you for your visit.